everyone, I am Dr. Priti Anand, and with regard to the part 3 MRCOG part 3 various type of stations which you come across in your exam, today I'll be discussing the SRH module. So just starting with the quote, don't let a bad day make you feel like you have a bad life. Just go on with the flow. How much you can study till exam and be consistent is the basic key of your journey. Now, SRH module, actually the cases are included with regard to the FSRH and the badge guidelines. So you can get stations which are either the simulated patient task or it can be a structured discussion. Now, what type of cases you can get in exam? So with regard to contraception, you can get regular contraceptive station that the patient is coming to you for the implant, IUS, CD or anything, or a contraceptive pill. But there will be always a twist in these stations. They might be having certain contraindications. So you have to definitely take information gathering should be very important in such stations. Same, you can get station for LARC method. The patient is coming to you for the LARC method. Again, the regular contraception, but the patient has risk factors, postpartum contraception, emergency contraception with domestic violence, intrauterine device with intrauterine pregnancy, undergoing leads and coming for emergency contraception, young patient wants sterilization, the reversal of sterilization or contraception in 18 years old or younger females with the learning disabilities. What cases we can get with regard to the infections, sexually shared infections, PID with domestic violence, TO abscess, sexually transmitted infection, termination of pregnancy, sexual assault, HIV in pregnancy, HIV in labor, HIV patient in labor, HSV in young girl, HSV in adults, syphilis in pregnancy, HSV in pregnancy. So how do we prepare this module and what are do's and don'ts? Most important, and what is one of the most important tasks I'm going to discuss with regard to the module. Also, I'll take you through two important new guidelines, basically a TO abscess and a HSV in pregnancy. They have come up with the newer guideline of HSV in pregnancy. So I'll just take you in brief about the important points related to that. So how to prepare? With regard to communication, make sure your communication does not feel judgmental to the patient or anybody who is accompanying the patient. So you should have a non-judgmental attitude, ability to communicate with teenagers and encourage them to involve parents or guardians. Now, when I say encourage them, that does not mean you have to force them that I'll only give you the information if you come with your parents. Okay, it's not like that. Communicate bearing in mind sensitivities like subject itself, beliefs, societal perception, labels, sexual diversity, and age of maturity. With infections, always talk about the contact tracing, rationale of follow-up, implications for fertility. Communicate with teenager and encourage them to involve parents, which we have already discussed. And when the patient comes to you for termination of pregnancy, deal with any clinical situation in a sympathetic but objective manner. Communication with the colleagues, ability to prioritize your case, ability to communicate with colleagues, especially with the gum cleaning, family planning services, about differential diagnosis and treatment, ability to describe the differential diagnosis and formulate an appropriate management plan. You need to be aware of the other care workers who would be involved in patient's care and understand when they should be involved with her permission and potentially when they should be involved without her permission if you are dealing with safeguarding issues. With regard to information gathering, definitely you will be talking everything in detail about her presenting complaints, her obstetric history, her menstrual history, past medical and surgical history, any family history of concern, her personal history, her social history, her occupational history, any history related to the allergies, blood group, reservations for blood, smears are very important, and sexual history. So everything is very important. So detailed sexual history should be asked in a very sensitive manner. Intimate, timely, and appropriate investigations. Use them to formulate a well thought out management pathway, and rationale for follow-up should be talked about. Contact tracing, contraception for the future should be asked. With regard to applied clinical knowledge, Sensitive conversation is very important with them about their sexual needs and all aspects of family planning. Sexual health needs of vulnerable women such as young women, sexual workers, drug abusers will be different and therefore should require that different approach and an appropriate pathway. Correct application of laws on termination and of pregnancy and sexual offensive acts is very important. And lastly, very important to give them the knowledge for the safe sex practices. Patient safety is very important in these patients. Every station has a very important, patient safety has a very important role. This domain is very, very important. So refer to GUM clinic or family planning clinic wherever it is required. So it is a patient safety point. Do remember the patients who are coming to you for contraception or STI advice, with STI infections for management. Do not forget to rule out the pregnancy. Ask about allergies, blood group specifically who is coming to you for the termination of pregnancy. UPT required should be done. Condom advice should be given. Smears is very important to ask over here, and ability to demonstrate issues of clinical governance around this subject. So blood group and smears are very important. Okay, with regard to do's and don'ts. So do's are, it is your duty to understand the sexual needs of vulnerable women such as young people, sexual workers, drug abusers. Signposts for the sexual history, signposts for personal history, correct application of laws of termination of pregnancy, mention about the GUM clinic when required, mention about the family planning clinic when required, rule out pregnancy when required. Do not forget to mention about partner contact tracing. Do not forget to mention STI screening. Do not forget to offer safe sex practices. Do not forget to ask about the blood group, smears, any further contraception she wants after the emergency contraception or because she's suffering from STI, and do not forget to ask about the allergies. Don'ts means do not be judgmental, specifically for the young girls, teenagers, and sexual workers. Don't force teenagers to inform parents if they have mental capacity and fulfill the phrase's competency. Do require, you will offer them to involve their parents. You will never force them, or you will not say that you have to be accompanied by somebody elder if she's less than 6, unless you are accompanied by them, I won't give you the treatment. Okay, it's very, very important. Please understand, if they have mental capacity and they fulfill the phrase's competency, you cannot deny contraception or any other management to them. Okay, so I'll be taking you through one of the stations, one of the cases of SRH module, very commonly asked in your exam in different ways, and it is really important. Okay, so my station is basically a simulated patient task where you'll be meeting a young girl, a middle-aged girl of 28 years old, Mary. She's a science student. She has regular periods. LMP was 13 days back. You had that patient, Mary, had recently had an abnormal smear for which she underwent a punch biopsy and it was diagnosed to be SYN3. Okay, only punch biopsy was done. She's scheduled for Leeds today, but she had an unprotected intercourse with her boyfriend last night. She wants emergency contraception. You are not planning to have babies now, and you are also going to have Leeds today. So there are two things. This patient is going to have Leeds today. This patient is also coming to you on the same day for emergency contraception because she's not planning babies now. For the time being, she's not planning. So what we need to do? So very important, look, role players will have a detailed script about the history of presenting complaints, that she's a 28 years old. She's coming to gynec clinic. She has Leeds today. She wants an emergency contraception. So she has to work today. The Mary had unprotected intercourse with her partner 2 times in last week. One was 4 days back. You are not sure. She's not sure about how many hours ago, but the recent one was last night. With regard to obstetric history, she has 1 abortion. Menstrual history, she has a regular normal flow. LMP was 13 days back. Regular cycles of 30 days. That means this is very important in history taking, because here when the patient is coming for emergency contraception, we need to know whether she is coming pre-ovulation or post-ovulation. So this history is very important. She smokes, she takes alcohol, her BMI is 23. Again, BMI is very important. Why? Because the dose of oral drugs will depend upon BMI. Okay, in case LNG, copper IUCD, you're not giving her then. No medical or surgical problems, no allergies, no family history of concern, only partner, she's happy. She wants coil, as a friend has told that it is very effective. She has taken oral pills once and she got pregnant on them, for which she underwent the termination. So she is not looking for the oral pills. Because of this reason, she does not want oral pills, I think so. Let's see. Use of condoms when needed, means occasionally, not regularly. Never sexual infection for her or her partner. Always had regular smear and they have been normal. So this smear was abnormal. Okay. No reservations for blood. Again, a very important history. Any patient who is going to have a surgical treatment, it is very important to ask for the reservations for the blood. Again, you ask if oral pills are as effective as coil. You ask if the procedure can be done safely with IUD inside the womb. Please make sure you insist for coil, as it is more effective in preventing unwanted pregnancy, but agrees if explained well. With tablets, you feel very nauseating, so you are worried for pills too. So there are various reasons. On pills, she became pregnant. She feels nauseating with the pills. So there are two reasons that she won't take the pills. Okay. And also her coil she is preferring because one of her friends has told that the coils is best. But the problem is she is going to have leads today. So whether you will give her coil and do the leads, you will postpone leads. So this is basically the station. Okay, let's see. Communication, greet, introduce yourself, check her name and age, consent to proceed and explain the nature of discussion, allow the patient to express the concerns without interrupting, maintain the eye contact, good posture, set an agenda, assess the patient's perception, organize structural approach, and provide information in chunks. Information gathering, once you have done the introduction, confirm the name and age, greet, agenda, setup. First thing, can you tell me more about your concerns? So she'll tell you everything. Okay, I had previous smears, they were all normal. This time the nip smear was abnormal, for which I underwent a biopsy. A small tissue sample was taken. It was abnormal and I'm going to have the major procedure, that is the removal of that part which is involved by the procedure. And because she has already been told about it, that is why she's coming for this purpose. So she can tell you everything. So don't worry about that. But you have to have an open question. Also, she will put in this that, okay, because I'm having leads today, but I had an unprotected intercourse and I'm not looking for babies and I want the emergency contraception as well. Okay. So she has two concerns here, that she will, if you will ask an open question, she will tell you everything. If you'll ask, okay, tell me about your smears, then tell me about leads, then tell me about your unwanted intercourse, then it will waste your time. You have to have a lot of time for your applied clinical knowledge. At the same time, information gathering should also be complete. Okay. Now, confirm the intercourse history. So, sexual history after signpost, very sensitive, don't be judgmental. Menstrual history in detail with the last menstrual period. Make sure she is post or pre-ovulatory, which you have to confirm. She is pre-ovulatory, then you can give oral pills and copper coil. She is post-ovulatory, you can give only copper coils. And she has missed the period, then the UPT has to be done. Okay, so LMP here is very important. Then her partner's sexual history of screening of STIs, any contraception use, obstetric history, if any, I mean any babies or anything she had in the past, her medical or surgical history of importance, any drugs she is taking, any allergies she has, any personal history of smoking, alcohol, social history, whom does she live with, what is her occupation, what is the support at home. So you can summarize if you like, and ask permission to examine if it is required. Okay. Now, applied clinical knowledge, here we have two issues. One, the patient is undergoing leads today. Second, she is coming for emergency contraception. Please remember, you need to know everything. You have to rule everything with respect to contraindications for the coil and the pills. Okay. And we have seen that she has two issues. One, she got pregnant on emergency pills in the past. Second, she feels nauseating with the pills. So might be she won't agree with the pill. That also you have to keep in mind. Again, one important thing. Do remember, you won't postpone leads. Please remember it. Doing leads today is a patient safety point. If you say, okay, you take the coil for 5 days and come back after 5 days, then I'll remove the coil and do the leads operation. No, absolutely wrong. You have to give the treatment for emergency contraception today as well as you have to do the leads today. Both are patient safety points. So with regard to the management of emergency contraception, we have coils, we have pills. In this case, she is going to have leads today. So whether you will give coil or not, that is important. Okay. Now you have to see that what is best for her. According to newer guidelines, what they say is you can do leads, you can put coil. Okay. But the patient carries high risk for bleeding, infection. Okay. So with discussion with the patient, it is good that any type of intrauterine device should be put 4 to 6 weeks after leads, because that reduces the risk of heavy bleeding as well as infection. Okay. So this you have to explain to the patient. I'm not saying it can't be given. It can be given. But again, it carries a high risk of infection and bleeding at that moment. Okay. And might be the healing is not good. So they propose now that preferably it should be after the gap of 4 to 6 weeks. So any intrauterine device should be given after a gap of 4 to 6 weeks of any surgery done on the cervix. Then what is the best option for her? If you explain her this and she agrees, okay, good, I will not take coil, then what are our options for me? UPA and LNG pill. Because this patient is LMP 30, that is, she's pre-ovulatory because her regular cycles are 30 days. And you can give coil and either of the pills to her. Now, with regard to efficacy, we know that copper coil is best because there is a problem of leads going on. So copper coil we will avoid, okay, after explaining to the patient. Second best is always a UPA, okay. So if she agrees, the UPA 30 milligram 1 dose is the best for her. But whenever you are giving pills, you have to explain their side effects, okay. First thing, they may feel little nauseating. If she vomits within 3 hours, she have to take full dose, another dose of the same tablet. Sometimes may cause a little headache or tummy pain. No serious and long-term side effects are seen. You have to explain to her, if your symptoms do not go away after a few days, come to us. If you think you become pregnant, or like your period got delayed, or there was a slight bleeding, do a pregnancy test. Or you have a sudden onset of pain in your lower tummy in rare situation, then you can come to us, because in that case, the fertilization of egg might have, the implantation would have been possible outside the womb, and this can be an ectopic pregnancy. Finally, invite her on questions, address her concerns, give her reference hospital number, and do not forget to give her patient information leaflet. So as I told you, if intrauterine copper device is removed during leads and not immediately reinserted, alternative, basically they want to say over here that with the leads procedure, you can give copper coil. Okay, you can give. It's not like that you can't give. You can give copper coil, but after explaining all the risks to the female. If you are giving copper coil at the time of leads, after the leads has done, it will result sometimes in bleeding, infection, discharge. Healing may not be good. Okay, so good is that if you are planning to use copper coil, it should be after a gap of 4 to 6 weeks, which is definitely not possible as an emergency contraception, because emergency contraception, she needs to be given today. What are patient safety points? They will definitely fail you in this domain if you don't ask about the allergy. Involve the patient in decision making, encourage them to express their ideas and their preferences, address the importance of sexual health screening, sensitively address the sexual health promotions, use of condom, which is very important, identify the risk and advise a correct plan of management, open and honest about the side effects without patronizing, confidentiality about the STI screening, condom use, and definitely any contraindications you have to rule out in the information gathering. For SRH stations, it is very, very important that once you finish the station, you have to ask about the long-term contraception, whether she is planning or not. So you can give her an advice and refer her to the family planning clinic here. And do not forget to tell her to protect herself and her partner from STI. So condom use is must. Okay, these two things are really very important. Finally, few important points of SRH module like TO abscess. So if the patient comes with TO abscess, you have to admit her and commence the IV antibiotics. If she has signs and symptoms of sepsis, so deal with the sepsis first. Okay, so sepsis is bundle, high flow oxygen, cultures of blood for blood culture, as well as blood for lactate, FBC, CRP, urea and electrolytes should be taken. Broad spectrum antibiotics given, review the microbiology, and if required, change the IV fluids and urine output should be monitored. If she gets improved, good. If not, then consider involvement of other specialists. Surgical and radiological drainage may be required. Improvement, good. No, then laparotomy may be required. She requires a one-to-one care in HD or ITU if she is not improving. If the sepsis is not present, she is just a case of TO abscess. Start with the treatment and the investigations. You can change the antibiotics once the microbiology report is there. If she improves clinically, then you can shift her from the IV to oral and discharge. Few words about HSV in pregnancy. So recurrent genital herpes, if that is diagnosed, or diagnosis of genital herpes in pregnancy, prior to pregnancy, treat recurrences. Basically, any recurrent herpes in pregnancy can be treated on the conservative management, that is the symptomatic treatment, and acyclovir if necessary can be started. Primary infection in first and second trimester, you start the treatment with acyclovir immediately, and both the case of recurrent herpes and the primary herpes in first and second trimester after the standard current treatment, that is acyclovir 400 mg TDS. Okay, you need to start it for 5 days. Then you have to start a prophylactic dose from 32 weeks until 40 weeks of gestation. Or the prophylactic dose needs to be started from 22 weeks for those who are at high risk of premature delivery. And thereafter, if because this infection occurred very earlier than the expected date of delivery, you can offer her the vaginal delivery. Primary infection, if occurs in third trimester, you will start the acyclovir and you will continue it till term. You can consider acyclovir 400 mg TDS till delivery. Recommend planned cesarean section if the infection occurred 6 weeks before the delivery. In the last 6 weeks, if it happened. So, antiviral drugs in pregnancy for herpes is acyclovir and valacyclovir. So, ideally, the standard treatment is given and followed by the basically a prophylactic dose from 32 weeks. Okay. So now the prophylactic dose starts from 32 weeks, not from 36 weeks. So for the people who have recurrent herpes or primary herpes in first and second trimester. People whom you might require to start it from 22 weeks who are at high risk of delivery, there you have to give 400 mg twice daily. Okay, as a prophylactic dose twice daily from 22 weeks, or valacyclovir 500 mg once daily from 22 weeks. If the patient have premature rupture of membranes, then you can give the IV drugs. Okay, so once you have given IV, then you change from IV to oral drugs from 32 weeks if they are able to continue the pregnancy. These are some charts with regard to the neonatal management. So neonatal management for the female who has suffered HSV in pregnancy now depends whether the baby is at highest risk, high risk, low or lowest risk. Okay, so there's a few details which you can go through. I have added them in the slides. Not very difficult, easy one. The most important thing everybody knows, the babies who are at high risk will always be given IV acyclovir. Okay, they will be very closely monitored. If they have any type of, if required, they may be swabs taken, there may be lumbar puncture which can be taken for the highest risk and the high risk babies. Okay, and these are the two groups where the treatment by IV acyclovir is required. Okay, so please go through these. They are little in detail, which is important from your exam point of view. So go through them. And if still you have any questions, do let me. I'm always there around in StudyMedic groups. You can join us for the part 3 preparation. And definitely for MRCG Part 1, Part 2, or various other courses we have in the Study Medic, as a not only for OBGY but for the other things also. And for OBGY full of MRCOG, EFOG, MRCPI, we have the standard groups, courses, very good team of mentors are there, so that are going to help you clear the exam in one go. Thank you so much and have a nice day.